Okay, so thromboembolic disease in pregnancy and the puerperium acute management, why it is so important? Because when you read the prophylaxis, everybody is reading prophylaxis more often, but there are many questions in the exam which is coming in the B guideline, and I feel that B guideline is more difficult. So I started with the difficult one, and tomorrow, day after tomorrow, we can do the prophylaxis. Okay, so introduction and the background epidemiology, we need to know the percentages, how common this is. Venous thromboembolism remain one of the main direct cause of maternal death in the UK, and the subjective clinical assessment of deep vein thrombosis, DVT, and pulmonary embolism is particularly unreliable in pregnancy, and only a minority of women with clinically suspected VTE have the diagnosis confirmed when objective testing is employed. So this is important that only minority of women clinically suspected have confirmed diagnosis. Okay. So the prevalence of ultimately diagnosed pulmonary embolism in pregnant women with suspected pulmonary embolism is 2 to 6%. So clinically, if you suspect that there is pulmonary embolism, you will confirm the diagnosis in 2 to 6% of women. So that's mean if there is 100 women come to you in the ER with the suspicion of pulmonary embolism, out of them only 2 to 6% will have pulmonary embolism. So you have to think about always the differential. The risk of antenatal VTE is 4 to 5 fold higher in pregnant women than in non-pregnant women of the same age. So, but the absolute risks remain low at around 1 in thousands pregnancy. So, although if non-pregnant women, then pregnant women, the risk is 4 to 5 fold, but overall the absolute risk is low, and it is 1 in thousand. Also, the venous thromboembolism can occur at any stage of pregnancy, but puerperium is the time of highest risk with estimate of relative risk of approximately 20-fold. So 20-fold more risk that the patient or the woman will have venous thromboembolism. Okay, so you will suspect acute venous thromboembolism during the pregnancy in women with sign and symptoms consistent with possible VTE, particularly if there are other risk factors for VTE. So every patient who is presented with bilateral leg swelling or unilateral leg swelling or breathlessness, you have to think first about pulmonary embolism, or you have to think in the differential diagnosis. How is acute VTE diagnosed in pregnancy? How we will diagnose? This is very important and common questions. It's coming in the exam. They're asking the diagnosis. The majority of women with VTE in pregnancy, they have clinical symptoms. The symptoms and sign of DVT include leg pains and swelling, usually unilateral, and lower abdominal pain, which is reflecting the extension of thrombus in the pelvic vessels and or development of collateral circulation. And the symptoms of pulmonary embolism include dyspnea, chest pain, hemoptysis, and collapse. These symptoms are very important because sometime in the exam scenario, they will give you the clinical symptoms, but the lab test will show, or the imaging modality will show that it is negative. But still, if the clinical symptoms are there, maybe you need to start the treatment. So you must know what are the symptoms of pulmonary embolism: dyspnea, chest pain, hemoptysis, and collapse. So these are the symptoms for pulmonary embolism, clinical symptoms. It is noteworthy that a low-grade pyrexia and leukocytosis can occur with VTE. So you have to think about even if there is a low-grade fever or a high TLC count, you still it is also a symptom sign of this pulmonary embolism or DVD. So diagnosis of acute venous thromboembolism, how you will diagnose. Okay. So how is acute venous thromboembolism in diagnosed in pregnancy? Okay. The clinical assessment of VT is not reliable for diagnosis. Okay. So less than 10% of women with clinical sign of DVD will have DVD confirmed. So you can see that if the patient will come to you 100 women, then out of only those 100 women, 10%, 10 women, they will have DVD, confirmed DVD. So all leg swelling are not DVD. So this less than 10%. This figure I took from strategy. So this is important figure. Sometime in the exam, they ask you the incidence or something or some question that you think that it's not in the green top guideline, then the second source is strategy. So in the strategy is written that clinically 10% diagnosis will be there. So any woman with sign and symptoms suggestive of VTE should have objective testing performed expeditiously and treatment with low molecular weight heparin given until the diagnosis is excluded by objective testing unless treatment is strongly contraindicated. So if clinically it's strong clinical suspicion, even before having objective confirmed test while waiting for modality to, you can start the treatment unless the treatment is strongly contraindicated, unless the patient is bleeding or there is a risk of PPH, unless you are while you are, this is very important because in the strategy the questions are like that, that the patient came with this is a clinical symptoms, clinical scenario in which you are suspecting DVD. While waiting, what you will do? So while waiting, start treatment. So this is the answer. Even sometimes they are giving you this option that you are suspecting the pulmonary embolism or you are suspecting the DVD and you call the internal medicine, your physician, your colleague, and while waiting, what you will do? So while waiting, you will start the treatment. Individual hospital have a good should have a agreed protocol for the objective diagnosis of suspected VTE. We are talking about both DVD and pulmonary embolism, and we talk about VTE during the pregnancy. So this may recommend the involvement of obstetrician, radiologist, physician, and hematologist. In our setup, usually they are asking the pulmonologist if they are suspecting the pulmonary embolism. This is the division between the hospitals, that who will see this patient if there is suspected pulmonary embolism. Here we have pulmonologists. We need to call the pulmonologist. But in the guideline, they say that you have to call the physician and you have to involve the hematologist. So you know which modality, which subspecialty you need to involve. All hospitals should have a protocol for the diagnosis of suspected VTE in pregnancy, which may require multidisciplinary involvement. Okay, if DVT remain untreated, why it is very important? Because out of those, 15 to 24% will develop pulmonary embolism if not treated on time. Pulmonary embolism during pregnancy may be fatal in almost 15% of the patients. So 15, if there is 100 women who have pulmonary embolism, the 15 women will die. And in 66% of these, death will occur within the 30 minutes of embolic event. So out of those 15 women, these 15 women will die. This out of these, this 15, 66% out of these 15 women, like two-thirds women will die within 30 minutes, like that. So what investigation are needed for the diagnosis of an acute DVDs? Now we think about DVD, come on the legs and think about DVD and the pelvic veins. We will, for the time being, will not talk about pulmonary embolism. Okay, so what we will do, the compression duplex ultrasound. This is the modality of choice. This is the first line. It should be undertaken when there is a clinical suspicion of DVT. And compression duplex ultrasound, it is a non-invasive test and should be first line in the investigation of DVD. And ultrasound is accurate in detection of thrombi above the calf and below the inguinal ligament. So below the inguinal ligament, above the calf, it is more accurate. And thrombi confined to the calf have a low tendency to cause pulmonary embolism. So if there is a in the leg muscle, in the leg area, the thrombi, it will have less chances that it will go to the pulmonary embolism. And this compression duplex ultrasound, especially, it's good in picking up the thrombi if it is above the calf, and if it is in the thigh, above the calf, below the inguinal ligament. Okay. So if ultrasound is negative and there is a low level of clinical suspicion, anticoagulant treatment can be discontinued. Okay, so you have less suspicion, but because patient came with unilateral swelling, then you ultrasound is negative, usually we are doing like that, and we are stopping the anticoagulant treatment. But if ultrasound is negative and there is a high level of clinical suspicion exists, anticoagulant treatment should be discontinued, but the ultrasound should be repeated on day 3 and 7. This is also very important recall question. Again and again, they have been asking, and students keep themselves confusing themselves. Why? Because if clinical suspicion is high, still we will stop the anticoagulant treatment and we will repeat the test on day 3 and day 7. Okay, we are talking about here the treatment. We are talking about in this guideline, we'll talk about the treatment doses. We will not talk about prophylaxis at all. So keep in your mind that anticoagulant treatment should be discontinued, but maybe she is postpartum and she is within 7 days or 10 days and she has other risk factors for postnatal prophylaxis. You will continue the prophylactic dose, but the treatment should be discontinued. So this is a very any point that you should keep in your mind. Maybe in the EMQ there is an option of prophylactic dose is there, and maybe the risk factor in the question there will be the risk factor. Then you have to think about the prophylaxis dose, if indicated, should continue, but the therapeutic dose should be stopped if the ultrasound is negative and still you suspect the clinical suspicion, and you will repeat the test on day 3 and day 7. Okay. And then if repeat testing is negative, no further treatment is required. Okay. If repeat testing confirm the presence of DVT, anticoagulant treatment should be recommenced and continued. Okay, so while iliac vein thrombosis is suspected, how you will suspect? Because patient will have back and buttock pain, and she might have swelling of the entire limb. Doppler ultrasound of the iliac vein, magnetic resonance venography, or conventional contrast venography may be considered, although in practice, because of the extensive natures of these thrombi, ultrasound venography will often suffice. So they are talking about which one, which imaging modality will be more helpful. So if you will do pelvic ultrasound, for example, if you will do pelvic ultrasound with color Doppler, this test may be helpful when thrombosis in the pelvic vessel is suspected and can be performed at the same time at the duplex of the lower limb. So what you can do, if you have a suspicion, then while doing the duplex ultrasound for the legs, you can do a pelvic ultrasound with color Doppler to rule out the pelvic vein thrombosis also. Okay. So what is another test which is called the magnetic resonance venography? I will show the diagram for this modality. Definitely you will inject the dye and then you will see the MRI. Or there is another method, conventional contrast venography. So magnetic resonance or contrast venography may be considered when Doppler ultrasound is negative and when there is a strong clinical suspicion of iliac vein thrombosis, especially if there is a back and buttock pain. So if your routine, your first line ultrasound, you is negative, but still you feel that there is still the clinical suspicion is high, you can do magnetic resonance venography or conventional contrast venography if MRI is not available. So this is the Doppler. This is the pelvic ultrasound with Doppler. Okay, so I think this one is this is not the one related to this one. This is not the one. I will show another because there is another diagram. This is not the one. This is not the MR venography. What investigation are needed for the diagnosis of an acute pulmonary embolism? So now we will come to the pulmonary embolism. What you will do? DVD you do duplex ultrasound with color Doppler, then MR venography or conventional venography. Step by step you will do. So if there is a pulmonary embolism, what you will do? First of all, clinical. What are the clinical signs and symptoms? There will be in the history sudden pleuritic chest pain, shortness of breath, hemoptysis, dizziness, faintness or collapse, tachycardia, tachypnea, hypoxia, raised GVP, and chest may sound clear. Symptoms and signs associated with DVD. So these are the clinical. Okay, again, the clinical assessment of pulmonary embolism is not reliable for diagnosis. So like DVD, only 10, I think 10, 15% or 10%, I think 10%, yeah, 10% women will have confirmed diagnosis if clinical suspicion. So here only 5% of women with clinical sign of pulmonary embolism will have pulmonary thromboembolism confirmed. These two figures I took from strategy. They said DVT only 10%, you will diagnose, confirm diagnosis, and for pulmonary embolism, only 5% with clinical sign, you will end up with confirmed diagnosis of pulmonary embolism. So any woman with sign and symptoms suggestive of a VTE should have objective testing performed as soon as possible, and such women should be started on treatment with low molecular weight heparin until the diagnosis is excluded by objective testing. So you will give treatment while waiting for objective testing. You will not waste the time. Okay. Women presenting with signs and symptoms of an acute pulmonary embolism should have an ECG and chest X-ray. Okay. So if a woman have suspected pulmonary embolism who have also sign and symptom of DVD, what you will do? You will do compression duplex ultrasound first line. Then if compression ultrasound confirm the presence of DVD, no further investigation is necessary and treatment for venous thromboembolism should continue. So if the patient have DVD with suspected pulmonary embolism, you just do ultrasound. If ultrasound confirm the diagnosis, no need to do other tests, no need to do, because now you can clinically you can confirm that this dyspnea and shortness of breath is because of pulmonary embolism, so you will start the treatment. Okay, in women with suspected pulmonary embolism without signs and symptoms of DVD, then ventilation perfusion, lung scan or CTPA computerized tomography pulmonary angiogram should be performed. So which one, which will, it will be depends that what is your hospital protocol, what the woman wishes, because you will counsel, and what is available for currently available. So accordingly, you will decide which modality because you have suspected pulmonary embolism. When the chest X-ray is abnormal and there is a clinical suspicion of pulmonary embolism, CTPA should be performed in prefer to a ventilation perfusion scan. So majority of the pulmonary embolism, if the patient have massive pulmonary embolism, sometimes chest X-ray is normal. Okay, very low number of people who have chest X-ray abnormal in pulmonary embolism. So if chest X-ray is abnormal, that means there is a high probability of having pulmonary embolism. So in this case, instead of doing ventilation perfusion scan, you will directly do CTPA. Okay, so this is a very important point. But if chest X-ray is normal and you suspect clinically pulmonary embolism, then you will go for ventilation perfusion scan. So this is the ECG. This is ECG. I don't know. This is for in ECG. What you will see, there will be the tachycardia, and there will be the pattern S1 in the lead one. There will be the S waves. Okay, maybe these are the S waves. Lead one S waves, and Q3 in lead 3 there will be a Q waves. I don't know this is a Q waves or no, and T3. So T wave inversion. Yani this one S1. Q3 and T3. So this is the pattern, but this pattern, very low number of cases will have this pattern. And also there will be right bundle branch block, right heart strain. So I don't think so in this CTG there is right heart strain. Need to see this one. Yeah, maybe because here you can see the R waves are very in the lead 1, lead 2, lead 3 and lead 4, the R waves are very high. So most probably this is a right bundle branch block or strain. Okay, so V6 you see R wave is very small. So this is the typical pattern you will see in the pulmonary embolism. And in the chest X-ray, if it is abnormal, because majority of the cases you can find the widen this mediastinum, and also the features of atelectasis, this collapse, effusion, opacity, all these findings you can find in the chest X-ray. Okay, so this is the ventilation perfusion scan. This is the I think this is the ventilation, and this one is the perfusion, because the blood vessels are shown clearly. This is the ventilation perfusion scan. Okay, so this is MR venography. You can see here. You can see there, it is this one is the MRI. Okay, this overall, this is the MRI picture. And here in the femoral, common femoral vein, this is the common femoral vein, this is the one. And here there is a blood clot. So here you can see, here the blood flow is stopped because of blood clot is here. So like this MR venography you can do, and you can see the clot, thrombus in the MRI, this view. Okay, here also this picture you can see here, this is femoral vein, and this is femoral artery. Okay, so I don't know, this one is not you can see, but only thing I want to show you here, in this one, this black area, it shows that there is no blood flow. And then this is the femoral artery, it is showing the blood flow. So that's mean that there is a blood clot is here. So this patient is B. Patient B have this one, this one is DVD, and this one is not a DVD. Because sometime I don't know, this picture is from strategy, maybe in the exam now they are more fond of giving the pictures. So maybe they will give the picture like that. So you, and they will ask which patient, patient A or patient B, which patient have DVDs. At least you should know how to interpret the findings, X-ray for pulmonary embolism especially. Okay, so alternative or repeat testing should be carried out where ventilation perfusion or CTPA is normal, but the clinical suspicion of pulmonary embolism remains. So, if both tests are normal, but still you think that patient need repeat testing because clinical suspicion is high, then you have to go for alternative testing, or you have to go for repeat testing in those cases. But it's not clear in the guideline when or which test actually you will do. But they are saying you have to go for maybe you want to do echocardiography, you want to do this pulmonary angiography, so you have to go for other tests. Anticoagulant treatment should be continued until pulmonary embolism is definitely excluded. So until then, you will not exclude, you will continue the treatment. Okay, so women with suspected pulmonary embolism, it should be advised that that compared with CTPA, ventilation perfusion scanning may carry a slightly increased risk of childhood cancer, but is associated with a lower risk of maternal breast cancer. In both situations, the absolute risk is very small. So in the pregnancy, we prefer the ventilation perfusion scanning. Why? Because the risk of radiation is less with the ventilation perfusion scanning. But again, the risk for features is little bit high. Absolute risk is definitely very low, but as compared to CTPA, the radiation risk for more after 15 years, the childhood cancer risk is slightly increased in ventilation perfusion scanning. So you need to consult the woman, and because CTPA have more radiation, maybe 20 to 100 times more radiation than ventilation perfusion scanning, and the patient can have a risk of breast cancer because of this high radiation. So you need to consult the patient accordingly. Where feasible, women should be involved in the decision to undergo CTPA or ventilation perfusion scanning. Ideally, informed consent should be obtained before these tests are taken. Definitely, if clinically indicated, if chest X-ray is abnormal, and you in this situation the mother life is in danger, then you will definitely go for CTPA. Okay, but when clinical suspicion is there, in this case, you know that CTPA is better modality, better predictive value, but still you will go with one which have less radiation exposure. But still you have to balance the risk after taking the woman consent. So first of all, ECG, this is important to perform as it may exclude a myocardial infarction. So what is the benefit of doing when you suspect a patient clinically, or patient is came to you in the ER? First of all, there is a clinical suspicion. So while ordering the objective testing, you will start the therapeutic treatment clinically indicated. Okay, so after that, definitely you will, at the same time you will doing before giving the therapeutic dose, definitely you will do the blood testing also, and at the same time you can do ECG. ECG is important because patient if came to chest pain, you have to exclude the MI, because now the pregnant women, they are more and more becoming pregnant at the higher ages, advanced ages. So ischemic heart disease risk incidences is increasing. So this is the chance you can pick if the patient might have MI. Typically, there will be a sinus tachycardia. The ECG, this is pulmonary embolism features. Sinus tachycardia, the ECG may show right axis deviation, right bundle branch block, or peak P wave in lead 2. The S1 T3 Q3 pattern is not often seen. It's not very common. In the guideline, it's written that in pregnancy and the puerperium, one study found that the ECG was abnormal in 41% of women with acute pulmonary embolism. The most common abnormality were T wave inversions. T wave inversion is the most common in 21% of cases. The T wave will be inverted, and S1Q3 T3 pattern will be present only in 15% of cases. And right bundle branch block, because strain on the right heart, 18% in the pregnancy and 4.2% in the puerperium. So this one you need to see, because why we can confuse these ECG changes, because in the pregnancy there is, in the lead 3 there is T wave inversion. In the pregnancy there is right heart strain normally. So that's why there will be confusion also. The ABG's analysis of limited value. Okay, now you do patient in the ER with the symptoms, you do ECG, and then you do ABG analysis. This is the bedside testing you can do immediately. ABG analysis, limited diagnostic value. Arterial blood gases result, what you can see, because patient will be have tachypnea. She can have respiratory alkalosis with hypoxemia. Often the carbon dioxide will be low due to the increased respiratory rate. Okay, and oxygen saturation at rest and after exercise may show a resting hypoxia or fall in oxygen saturation after exercise. She will not do exercise, maybe after moving from one bed to another bed, you will see there is a decrease in oxygen. So chest X-ray may identify other pulmonary diseases like pneumonia, pneumothorax, or lobar collapse. So you have to do chest X-ray also. These tests immediately you can do. While the chest X-ray is normal in over half of pregnant patients with objective proven pulmonary embolism. So you can see that in proven pulmonary embolism, only 50% will have abnormal chest X-ray. So normal chest X-ray will not exclude pulmonary embolism. Still, if the clinical suspicion is there, you will do ventilation perfusion scanning. Abnormal features caused by pulmonary embolism include atelectasis, diffusion, focal opacities, regional oligemia, or pulmonary edema. Okay, so now we'll discuss about the radiation doses. The radiation dose to the fetus from a chest X-ray performed at any stage of pregnancy is negligible. It is less than 0.01 MSV. A chest X-ray should be performed before deciding upon further diagnostic test in women with suspected pulmonary embolism without sign and symptom of DVT. Because if there is a sign and symptom of DVT, ultrasound will become positive. You don't need to do any of these tests at all. If you have this woman with sign and symptoms of DVT, a ventilation perfusion lung scan should be performed. You see here that chest X-ray should be performed, and then if women have no sign and symptom of DVT, you can perform a ventilation perfusion scan if the chest X-ray is normal. Okay, and CTPA should be performed if the chest X-ray is abnormal. So don't confuse. If chest X-ray is abnormal, directly you will go to higher test CTPA. And if chest X-ray is normal and clinically suspicion of pulmonary embolism without DVT, then you will do, after chest X-ray normal, you will do ventilation perfusion scan. A chest X-ray may also show a widened mediastinum in the aortic dissection. So in the strategy, they talk about this question that patient on the X-ray show widened mediastinum. So think about aortic dissection also. Slight increase opacification, otherwise normal chest X-ray. So this is the chest X-ray of massive pulmonary embolism. A patient have massive pulmonary embolism, and you can see there only there is an increase opacification here. That's it. Rest of the chest X-ray is normal, and this is the X-ray of massive pulmonary embolism. Okay, so pregnant women with suspected pulmonary embolism who have sign and symptom of DVT should have bilateral compression duplex ultrasound. We discussed already this one. A diagnosis of DVD may indirectly confirm a diagnosis of pulmonary embolism. And since anticoagulant therapy is the same for both conditions, further investigation may not be necessary. This would limit the radiation doses given to the mother and the fetus. So this is very clear. The role of ultrasound leg studies in pregnant women with suspected pulmonary embolism. Now, if patient have suspected pulmonary embolism and clinically there is no sign and symptom of DVD, you want to do a leg ultrasound. This is unclear because given the higher incidence of isolated iliac weight DVD in the pregnancy, it would be anticipated that there will be increased likelihood of false negative result with this strategy. So if you want to do, you will maybe the leg ultrasound will be negative because there is clinically, but still the pelvic ultrasound, the iliac vein thrombosis you cannot exclude until you go specifically for pelvic vein ultrasound, pelvic ultrasound. Therefore, while a positive test is of value, a negative investigation does not help to exclude a pulmonary embolism. So, if clinically the patient has pulmonary embolism and no sign and symptom of DVD, you will not do leg ultrasound. Or in either way, maybe because you want to, if you want to do better, to do pelvic ultrasound also to exclude all, or either don't do at all. Echocardiography, in some cases, portable. This is the other test, or this is the test. Sometime you want to do. It's not always you want to do. Sometime you want to do. Maybe you have you cannot arrange CTPA urgent, but you have echocardiography nearby. So what will happen? It will help if patient is hemodynamically compromised and it's too unstable to move to the imaging suite for the CTPA. In this scenario, if there is a large pulmonary embolism, there may be a evidence of right atrial or ventricular dilatation or strain. So in echocardiography, you can see this one. So a thrombus may be noted if very proximal in the pulmonary artery. If it is very low and very proximal in the pulmonary artery, even by echocardiography, you can see here. An echocardiogram may be helpful in the differential diagnosis of aortic dissection where there may be aortic regurgitation. So echocardiography will help you in two, if there is a big pulmonary large embolus, and it will help, or if there is a aortic dissection or aortic regurgitation will be there, and you can it will help in differential diagnosis, like ECG will help you in the differential diagnosis. Okay, there is a role of echocardiography in hemodynamically stable patients, particularly with a bilateral pulmonary embolism or extensive pulmonary embolism, as evidence of right ventricular dysfunction indicate worse prognosis. So these women will need follow up with a respiratory physician. So they said echocardiography will help also, even in the established case of pulmonary embolism, because it will help what is the ventricular function, what is the ejection fraction, how much. So it will help you to for the prognosis of the patient. So even in that scenario, the echocardiography can be helpful. And also this blood troponin levels are needed in women presenting with chest pain to rule out the MI. So this blood troponin level and the detail of the echocardiography, this is in the strategy. This is not from the guideline. Guideline just mentioned about the echocardiography as an alternative or other therapies, but and because recently, maybe 2 days before, strategy updated their website. So this is from the latest one. So they added the troponin level because they want to rule out the MI because of advanced maternal ages majority. And also they said the role of echocardiography is in the exclusion of other differential, and for the prognosis of the mass established pulmonary embolism, it's helpful. Okay, so angiography are combination of the techniques. Other techniques are angiography. You can do a pulmonary angiography or catheterization, and you can use the combination of the techniques. With regard to ventilation perfusion lung scanning during pregnancy, the ventilation component can often be omitted, thereby minimizing the radiation dose to the fetus. If you want to avoid the ventilation, you want to avoid the less, you want to have less radiation to the mother and to the fetus, then you will omit the ventilation part and you will do only the this one perfusion part. And while doing the perfusion part, studies have compared okay, so while doing the perfusion part, maybe If perfusion part is abnormal, then you will go for the ventilation part. If while doing the perfusion part, if it is normal, maybe you don't want to do the ventilation part. So in this way, you can do only perfusion part and less radiation to the mother. So study have compared ventilation perfusion or low dose perfusion scan with CTPA for the detection of pulmonary embolism in pregnancy, and have found comparative negative predictive value. So even CTPA, if it is 99%, for perfusion scan, it is 100%. And no significant difference between the number of positive, non-diagnostic and normal scans. So you can do safely without compromising the diagnostic value of the modality. So ventilation perfusion scan, this should be the first line diagnostic test when you have clinical suspicion of pulmonary embolism, when the chest X-ray is normal. And then very small radiation to this one. And also radiologist will perform the perfusion element of the scan first. If it is abnormal, then he will do the ventilation scan to look for mismatching. If the perfusion scan is normal, the ventilation scan does not need to be performed. Okay. Then treatment should be continued if there is a medium to high probability of pulmonary embolism. And if postnatal, the patient should not be breastfed her infant for 48 hours. So this is the precaution, that if it is postnatal patient and she have this ventilation perfusion scan, then the patient should not breastfed her infant for 48 hours. So this is the Q is the perfusion. Okay, you can see here this there is a pulmonary embolism because this not full lungs are showing the blood perfusion. The apexes are not there. So this is a picture of pulmonary embolism perfusion scan. And ventilation scan, I am not sure about this one, but definitely the perfusion scan is abnormal. So you can see here, this is the ventilation part and this is the perfusion part. It will look like this. So CTPA has potential advantages over ventilation perfusion imaging, including why I am emphasizing on my lecture on these two modalities, because the recalls always they are asking the comparison, the dose radiation, which one, this one or this one. That's why it's important. Okay, so CTPA. Okay, it's readily available. It's deliver a low radiation dose to the fetus. Okay, I'm talking about CTPA because mother radiation is more, but baby radiation is radiation to the baby is less. Can identify other pathologies including pneumonia, the pulmonary edema, and rarely aortic dissection. Okay, so many authorities continue to recommend ventilation perfusion scanning as first line investigation in pregnancy because of its high negative predictive value in this situation and its substantially lower radiation dose to the pregnant breast tissue. So ventilation perfusion scan less radiation dose to the breast tissue. The dose estimate for CTPA is 20 to 100 times greater than for ventilation scanning. So the radiation doses for CTPA is 20 to 100 times more than ventilation. That's why for especially for the young woman, the CTPA will increase the risk for breast cancer. So still going on CTPA. Okay. Sorry, did I confuse you? I don't know. Okay, so this is the investigation of choice if the chest X-ray is abnormal, when an urgent diagnosis is required out of hours, or if the differential of aortic dissection need exclusion. So this one is good when you have you need to exclude other conditions also like aortic dissection. CTPA only detects thrombosis to the level of segmental vessels and may not detect small pulmonary thromboembolism in the periphery of the lungs. So this is another little bit restriction. There is less radiation to the fetus, but a significant radiation to the maternal breast of up to 20 milligyre. So 10 milligyre radiation dose is increased the lifetime breast cancer risk by 13.6% above the background risk. So if background risk is there, by this 10 milligyri, the risk is increases 13.6%. So CTPA will give 20 milligyri. So it will be any high. This is the CTPA, and the arrow, red arrow, it's showing here the black, the defect. This is pulmonary embolism. You can see here. With both techniques, the doses employed are well below accepted threshold for teratogenicity, fetal death, and fetal IGR. And the main concern for the fetus is a very small increased risk of childhood cancer. Okay, so International Commission on Radiological Protection has estimated an increased risk of fatal childhood cancer to the age of 15 if in utero exposure to 0.6006% per milligare, which required to a risk of 1 in 17,000 per milligare. This I took from guideline. Okay, in the guideline they say that if they talk about generalized thing, that if somebody get radiation dose uh, which is like milligare per milligare 1 milligare, then the risk of developing childhood cancer will be 0.006%, or it will be if 17,000 baby will receive 1 milligare, then the one baby will get the childhood cancer. So either you can say like this 0.007, or you can say 1 in 17,000 risk per milligare. 1 milligare risk of 1 milligare radiation will increase this much risk. And you can see here for maternal, for 20 milli, we are talking about 20 milligare or 10 milligare radiation dose increase 13.6%. So it's very high. The CTPA dose risk is very high. This is a high dose. 10 milligare is very high. Okay, so ventilation perfusion scan, we will see how much it risk, but usually they are talking about 1 milligare will increase this much risk. So how many milligare by ventilation perfusion scan, we'll see now. So the fetal radiation exposure associated with CTPA and ventilation is, with CTPA it will be 0.1 milligare for the baby. It is not even 1. Okay, and for ventilation perfusion, the risk to the fetal radiation is 0.5 milligare. So it's low. It's still less than 1. Okay, so although quoted figures vary considerably, so you can see here even both modalities, fetal radiation exposure is very low as compared to mother. While CTPA is associated with the low risk of radiation for the fetus, this must be offset by the relatively high radiation dose, 20 milligare to the mother breast tissue, which is associated with increased risk of breast cancer. And it is again and again I am writing same thing anyhow. Okay, so already we discussed this one, the estimation that 10 milligram increase. I think I repeated the slide. Anyhow, no problem. For a 25-year-old whose background risk of developing breast cancer, if 10 years, the background is 0.1%. For example, if a 25 years old woman at 35 years of age, her background risk of breast cancer is 0.1%. So you give this extra doses of 10 milligare of radiation, and it will increase the risk by this is the lifetime risk. So you will increase 0.1%. So this is 0.0136% extra risk. It's very confusing, but you need to know this 13.6 is lifetime risk. Okay, and then because of this extra exposure, the risk increases 0.1%. So this much is the extra risk this woman will face if she will have this CTPA. So why it is important in the counseling of the woman? Okay, and already I think we already discussed this thing. You can prevent this one. This is from the strategy that you can decrease the risk by using the bismuth shields placed over the breast. By this, you can decrease the risk 20 to 40%. And also, okay, so in these cases, if young women, you better to do lung perfusion scan. You should do, because especially if the family is to breast cancer or if the patient have previous chest CT scan, in these cases, better you offer patient the perfusion scan. So because young women, for example, the scenario they give you 18 years old or 20 years old, mother have family history of breast cancer, or she have previously chest CT scan because she has trauma, and because of that she has multiple CT scan. Now she came with suspicion of this. Now in this case, you have to select perfusion scan because now she has other risk factors also, especially young women. Okay, they talk about theoretical risk of hypothyroidism for neonates who have been exposed in utero to iodinated contrast medium because CTPA, they use iodinated contrast medium. So there is a theoretical risk of hypothyroidism. They have newer imaging technology which is for pulmonary rhythm, which is called the magnetic resonance pulmonary angiogram. This is MR pulmonary angiogram, or there is a digital subtraction angiography, and there is a ventilation perfusion single photon emission computed tomography. This is the abbreviation. Ventilation perfusion single photon emission computed tomography. These three are latest techniques. Okay, so should D-dimer testing be performed prior to objective diagnosis? Should we do? Okay, so well score is doing when they are estimating. I exactly don't know the detail, but in the guideline they talk about this scoring in the non-pregnant woman. But in pregnant women, the well scoring and D-dimers, they are not validated in the pregnant woman for the diagnosis of pulmonary diagnosis of VTE. Because what happened, D dimers increase with gestation, postnatally, and with preeclampsia. Even test is negative, the false negative rate is unacceptably high with moderately sensitive D dimer assay. So, if the non-pregnant woman D dimer testing is successful, but for pregnant women, it's not successful. So what is the role of pretest probability assessment? They talk about this one, that pretest probability assessment for VTE in pregnancy, it's not helpful because they are if patient is not pregnant, maybe the pretest probability you can do. But in the UK, national guideline recommend that non-pregnant patient presenting with suspected VTE should have a 2-level well score, a pretest probability assessment. So well score is basically before doing the test, they have scoring. They are scoring, maybe doing scoring clinically or laboratory tests. There will be some scores, and because of base of those scores, they before doing the test, before doing CTP or ventilation perfusion scan, they will have scoring, and in that scoring they will say this patient has high probability or this patient has low probability. According to that, they will select the which modality imaging they want to do. But in pregnancy, they said it's not possible like that. Okay, so they said that pretest probability by VT experts could exclude DVD when the pretest probability is low. But they have three variables, and in this variable, the diagnostic accuracy can be improved. And this is all from the guideline because sometimes they can ask the things from the small points. They can ask. They talk about three variables, which is the left leg DVT in the left leg. If it is in the left leg, there is a more chance that it will be if there is left leg swelling, more chance there will be related to pregnancy. And if the calf circumference of at least 2 centimeter, for example, if the difference between the two calf is at least 2 centimeter, and if the patient is presenting in the first trimester, this is called a left rule. L is for left leg, and E is for edema, and FT is for first trimester. So left rule will tell you that most probably it is DVD. So this is called the pretest probability. They talk about this one. And also they talk about the modified Bell score, which is MWS. And they said they use it as a stratification tool in the diagnosis of pulmonary embolism. And they said that if it is a more than 6 or more than 6, it was 100% sensitive and 90% specific with positive predictive value of 36% for pulmonary embolism on CTPA. So if the patient have this well score less than 6, no woman have pulmonary embolism, so negative predictive value is 100%. So you can see that you should know the terminologies, the modified well score less than 6, more than 6. These are the pre-test probability test, and sometime they can use by VT experts. So baseline blood investigation, what baseline investigation you should perform before initiating anticoagulant therapy. So you need to do, because before giving heparin, you need to know CBC, platelet counts, coagulation screen, urea and electrolytes and liver function. That's the baseline. Without doing these tests, for example, any scenario, if you will find give heparin, or if it is strongly indicated, search for the blood test, because without doing blood test you cannot give heparin. Even you can give heparin without waiting for internal medicine specialist, but without give, because your guidelines allow you, but without giving heparin, without doing the test, you cannot give heparin. So think, search for this option, blood test. If blood test is not there, then you can choose, because you have no option. But first thing is blood test. Performing a thrombophilia screening prior to therapy is not recommended. I saw many scenarios and strategies, and they give you the scenarios that patient presented in the ER, and the patient have personal history of venous thromboembolism because of trauma, or she has family history of venous thromboembolism, or she's herself diagnosed case of thrombophilia. But none of this option give the choice of thrombophilia screening. They give in the options, but you should not select in acute condition. You will not select the thrombophilia screening. The use of anticoagulant therapy can be influenced by renal and hepatic function, and can definitely, if impaired renal function, you will the anticoagulant therapy will be influenced, and can influence, because definitely heparin, I think they are excreted by the kidney. So that's why kidney function, renal excretion is important. So you don't want uh, to do give this drug without seeing the kidney test, and can influence the platelet counts definitely. And blood should, because thrombocytopenia, heparin induced thrombocytopenia, and blood should be taken to confirm that these are normal before commencing the treatment. Almost half of the women who have an episode of venous thromboembolism in pregnancy will have underlying heritable or acquired thrombophilia. So you can see that 50% of the patient, if they have venous thromboembolism, 50% will have heritable or acquired thrombophilia. Even then, we will not perform thrombophilia screening, such a high risk, but we will do these baseline tests. Before doing, we will do baseline test. Okay, so if a patient is non-pregnant, whether she has thrombophilia or no, it will not alter the venous thromboembolism management and the choice of anticoagulant. We want to give her heparin, low molecular weight, or warfarin, or vitamin K dependent anticoagulants, or non-vitamin K dependent. We can give any type of this because she's not pregnant, but even intensive duration treatment. So therefore, testing for thrombophilia is not recommended. But the physiological changes of the pregnancy and pathophysiology of acute thrombus can influence the result of a thrombophilia screening. So that's why we are not doing, because of physiology and pathophysiology. It will not give you the right clue, because protein S normally falls during the pregnancy. So it is a normal physiological. So how can you diagnose somebody who has family history of protein S deficiency? Now she came to you 8 weeks pregnant. Then how even if you do blood test and it will show low protein S, you cannot conclude it, because you know the normal physiology, protein S will fall. So even then, you cannot diagnose protein S deficiency for this patient. Okay, so the level of antithrombin and proteins C may fall, particularly if the thrombus is extensive. So in addition, okay, they said that if thrombus is very extensive because of making coagulation, the antithrombin will be decreased and protein C will be decreased because of thrombosis. In addition, protein S level fall in normal pregnancy, and an acquired activated protein C resistance is found in around 40% of the pregnancy. So that's why they are not doing thrombophilia testing during the pregnancy. So it is recommended, therefore, that a thrombophilia screening should not be performed in pregnant women on presentation with suspected VTE. So what is the initial treatment of VTE in the pregnancy? Until now, we have discussed the incidence, epidemiology. We discussed how to diagnose DVT, how to diagnose pulmonary edema, pulmonary embolism, sorry. And we now we will discuss that what test we will do before that, and what is the initial treatment. Now the treatment come, what to do, what to give. Okay, so initial management of DVD involved the elevation of the leg and an application of graduated elastic compression stocking. So if the patient have clinically developed DVD, still you have to leg elevation and stockings you have to apply to the affected leg to help minimize the edema. Okay, and class 2 compression, uh, class 2 compression hosiery is more effective than class 1. So there is a type of compression stocking, and class 2 compression stocking is best than class 1. Okay, and early mobilization with compression stocking is encouraged and does not encourage the clot to detach and cause a pulmonary embolism. So you can encourage the patient to mobilize even, because it will not dislodge the clot and will go to the lungs and cause pulmonary embolism. No. In clinically suspected DVT or pulmonary embolism, this I took from strategy. Okay. In clinically suspected DVT or pulmonary embolism, treatment with low molecular weight heparin should be commenced immediately until the diagnosis. We already discussed this thing, that if clinically suspected, we will start the treatment immediately while waiting for objective testing after the blood test. So low molecular weight heparins, and there is unfractionated heparins, and there is warfarins. If postnatally we can give warfarins. So low molecular weight heparins more effective, less chance of hemorrhagic complication, low mortality than unfractionated heparin, and lower rate of recurrences or extensions, lower mortality, and less major bleeding during the initial treatment. Do not cross the placenta. So these are the benefits. So safe and effective alternative to unfractionated heparin as anticoagulant during pregnancy. Okay, so again, the same thing. One of the advantages of low molecular weight over unfractionated is the potential reduced risk of bleeding. With low molecular weight, the risk of bleeding is less. And also, this is relevant in obstetric practice because obstetric hemorrhage remain the most common cause of severe obstetric morbidity. Okay, so it's not associated with increased risk of severe PPH in vaginal delivery. Also, also the risk of heparin-induced thrombocytopenia is lower with low molecular weight compared with unfractionated heparin. So, if, risk of osteoporosis, heparin-induced osteoporosis with low molecular weight is 0.04, and with unfractionated it is 2%. Okay, if the patient is allergic to low molecular weight heparin, the alternative anticoagulated preparation like denapuride, you can use denapuride. So what is the therapeutic dose? Okay, first of all, you have to give the dose according to the booking pregnancy weight or early pregnancy weight. Okay, keep in mind early pregnancy weight or woman booking weight accordingly. And then there is insufficient recommendation. The guideline discuss about this thing once or twice daily. Some of the majority of the studies, they show that if giving twice daily, because in the pregnancy they talk about that the pharmacokinetics disturb, it changes. So either you give once daily or you give two divided doses. It's unclear. So if you will give once daily, it is preferable, and there should be clear local guideline. According to your guideline, use your guidelines. So majority they said once daily is better, but if you want to give two divided doses, not contraindicated. You can give two divided doses also. It's your clinical judgment or your local guidelines. But the guidelines, but the studies fail to fail to make preference which one is better. They fail to give any result. So during pregnancy, changes in volume of distribution and GFR result in alteration in the pharmacokinetics. So what will happen? There is a guideline from New Zealand and Australia, insufficient evidence to favor one dose regime over the other, and that treatment of acute VTE in pregnancy can be with low molecular weight heparin administered either once daily or twice daily. So they because half-life of enoxaparin is prolonged in the pregnancy, so author conclude that some of these studies or systemic review that further support is needed for once daily enoxaparin for the treatment. So they need more studies. The only thing they talk about that the half-life of enoxaparin is prolonged. So if you will give once daily, that's mean it will be also correct to give. So these are the doses, especially concentrate here. 50 to 69. Here the weight distribution before, because for prophylactic doses you can remember it's between 50 to 90 kg, but for therapeutic doses the weight between the weight there is very narrow difference. So 50 to 69 they talk about this one, then 70 to 89 different dose from 90 to 10. So be very careful when you are taking the dose and the weight of the patient according to therapeutic dose or prophylactic dose. So prophylactic dose, the range of weight is different, and for therapeutic dose it's very narrow. You can see here. So 50 to 69, 60 milligram twice daily or 90 milligram once daily. So it's not 120 milligram once daily, because if you want to divide it, uh, it's either 60 milligram twice daily, which will make it 120, but if you want to give once daily it will be 90. So sometime I don't think so they will ask you, but you should have some idea that how much dose you need to give, at least some idea, because in
If
one
50
of these,
kilogram,
sorry,
what dose to give? If 50 kilogram, what dose to give?
I don't understand what you are saying.
If the weight is 50 kilogram, what
Yeah,
dose to give?
I didn't I didn't talk about, because this is the extreme of weight. The extreme of weight is less than 50 and the more than 125. These are the extreme of weight. In these condition, you have to see, you need to discuss with hematologist. And for less than 50, you need to see, either you have to monitor the kidney function test or you have to monitor the coagulation test. You have to monitor, but not extreme, or if there is no renal impairment, then you don't need monitoring much. So that's why I didn't mention this one. These are the extreme of weight 50 or greater than 125. You need to discuss with hematologist. And 50, it's 40 milligram twice daily or 60 milligram once daily accordingly. So you can see here, either you remember this one, or either you remember this one.
Okay.
Okay, so this one is deltiparan. Deltiparan, again, you can see here, 6,000 twice daily or 12,000 once daily. So,
Excuse me, ma'am.
mhm.
So these are the prophylactic doses, right?
No, these are the therapeutic
No,
doses. These are
Okay,
therapeutic.
okay,
We are
sorry.
talking about,
Okay.
no. In this chapter, I told you, we are talking about the treatment. Forget about the prophylaxis, delete it.
Okay.
Because all the time, even in the groups, everybody is discussing about the prophylaxis, prophylaxis, prophylaxis.
Yeah,
That's
that's
why,
what it's
yeah, that's why
confused.
I,
Yeah.
by intention, I choose this one. Okay, now after that you
Okay,
can
ma'am.
go easily to prophylaxis, which you like to discuss, but therapeutic nobody want to discuss, even if yani this, because this is difficult, right? So we will do difficult thing first. So these are the
Okay.
therapeutic doses. So initial doses of tinzaparin, it's written that 175 units per kg once daily. These are all therapeutic doses. So okay, so lower doses of low molecular weight should be employed if the creatinine clearance is less than 30 ml per minute, which is for enoxaparin and dalteparin, or for that's mean tinzaparin, it's more renal kidney friendly, because if the kidney function is less than 20 ml per minute, then you will adjust the doses. So for tinzaparin, the threshold is 20 ml per minute. If it is so low, the GFR or creatinine clearance is so low, then you have to adjust the doses of tinzaparin. But for dalteparin and enoxaparin, it's a little bit higher, 30 ml per minute. If it is less than 30 ml per minute, then you have to adjust the doses. Okay. So what are the side effect of? So remember always, extreme of weight and extreme and the renal impairment, you need to adjust the doses, and you need to involve the hematologist, or you need to do monitoring. Okay, so side effect of low molecular weight heparin. I'm talking about low molecular weight heparin. Okay, side effect is osteoporosis, although it is very less. You, as compared to, we discussed this one, as compared it was 2% for heparin. I will just show you the slide. It is for osteoporosis, it is 2%, and for heparin, it is 0.04%. So other way is 1 into 500. So either way, you have to remember both figures, okay? And osteoporosis, which bones? Vertebral bones. Vertebral bones, they are more prone for osteoporosis because of this heparin. Okay, so 1 into 500, it is 0.04%. So it's the same, 1 into 500. 500 fracture rate can be severe vertebral prolapse. Okay, so this is low molecular weight heparin. For unfractionated, it is 2%. So allergy can happen, injection site bruising, thrombocytopenia, very rare with this one. Very rare idiosyncratic reaction. Platelet counts not need to be checked unless patient receive unfractionated heparin before low molecular weight heparin. So if you want to switch to UFH before you have given, now you want to switch, you need to check platelet counts. So you have to remember, when you are switching to one type of heparin to another, you need to check the platelet counts, because you have to make a baseline platelets, because with this one more risk, with low molecular weight less risk of thrombocytopenia. So should blood tests be performed to monitor heparin therapy in the pregnancy? So the next question will come. You will monitor the therapeutic doses during the pregnancy or you will not? So routine measurements of peak anti-10A activity or XA activity for patient on low molecular heparin for treatment of acute VTE in pregnancy or postpartum is not recommended, except if the patient has extremes of body weight, for example, less than 50 or 90 kg or more. So here they make it extreme of body weight less than 50 or more than 90. For them it is extreme, more than 90 is also extreme, or with other complicated factors, because they are talking about not prophylactic dose, they are talking about therapeutic dose. So for them the higher limit is 90. Okay, so or they have another complicated factors, like if renal impairment or patient has recurrent VTEs, because when there is thrombosis, definitely the coagulation factors also, like we discussed, that antithrombin and the protein the C levels also falls because of thrombus. So if there is a recurrent VTE, definitely coagulation will disturb. So in these cases, you need to monitor. Otherwise, you don't need to monitor routinely. And routinely, platelet count monitoring should not be carried out. But if you platelet count should be checked after 24 hours of initiating treatment if the patient have previously received heparin, like unfractionated or low molecular weight in the last 100 days. So if the patient have received heparin the last 100 days, you have to check platelet count after 24 days of initiating treatment. I don't understand this statement. Anyhow, it's written like that. If 3 months before patient receive heparin therapy, either it is unfractionated or low molecular weight rate, and now you have to repeat the treatment, that means maybe patient have recurrent VTE. So in that case, you will repeat the platelet count, you give the treatment, and after treatment you will repeat the platelets after treatment 24 hours. So this is something rare scenario. Okay, not all scenario, only the rare scenario you want to see the platelets after treatment, because maybe with the last 100 days the treatment might have some effect. So I don't know really. Any VT expert can answer this one. Okay, the frequency of heparin-induced thrombocytopenia is greater in surgical than medical patient. So, and it is more likely with unfractionated. We all know that. So it is therefore recommended that obstetric patients who are post-operative and receiving unfractionated heparin should have platelets count monitoring. Okay, now if the patient is receiving therapeutic doses of heparin and she has, for example, cesarean section, in these patients you will monitor the platelets every 2 to 3 days from day 4 to day 15 or until heparin is stopped. So this is important. From day 2 to day 3, you will sorry, from day 14 to sorry, from day 4 to 14, you will continue to monitor every 48 hours to 72 hours. You will start monitoring the patient like that from day 4. Okay, so especially the post-operative patient, the surgical patients. and if she's receiving the unfractionated heparin. Otherwise, low molecular weight heparin we are not using. Even we are giving therapeutic doses, we are not monitoring the patient like that. So should massive life-threatening pulmonary embolism in pregnancy in the puerperium be managed? How should? I think it's how should. Okay, if the patient is collapsed or shocked, it should be assessed by the team of experienced clinician in which including the on-call consultant obstetrician. And management involve multidisciplinary in which there is a senior physician, obstetrician, radiologist, and who will decide individual basis who will receive the intravenous unfractionated heparin, or either it will thrombolytic therapy or thoracotomy or surgical embolectomy. They will decide, because heparin will not dissolve the clot. Clot is there, and the it will not lyse the already the clotted one. So thrombolytic therapy is needed or no, it will be decided by the team. They will decide that which therapy this patient needed. Okay, so maternity unit should develop guideline for unfractionated heparin, because it is used in cases of massive pulmonary embolism or in cases where rapid reversibility is required, because only the antidote for heparin is protamine sulfate. For low molecular weight heparin, you cannot use the protamine sulfate for reversal. But the benefit of this one is that you can do reversal by using the protamine sulfate also. And also you can use it when you want to monitor, you want to make it reversal easily. So on-call team will be contacted immediately. Urgent portable echocardiography or CTPA within 1 hour of presentation should be arranged. So we are talking about CTPA. If it is not available, patient is collapsed, hemodynamically unstable. I talked before also. We can use the portable echocardiography, because if it is near to the pulmonary artery, this thrombosis, it can pick the ventricular strain. Even it can pick the aortic dissection. So if massive pulmonary embolism is confirmed or in extreme circumstances prior to confirmation, immediate thrombolysis should be considered. So massive pulmonary embolism may present with shock, refractory hypoxemia, and or right ventricular dysfunction on echocardiogram and is medical emergency. Okay, so you will do maternal resuscitation if cardiac arrest, CPR, left lateral position, perimortem cesarean by 5 minutes if resuscitation is unsuccessful and pregnancy is more than 20 weeks. So perimortem cesarean. Then why it is preferable treatment IV? Because of its rapid effects, extensive experience of its use in this situation, and the dose can be adjusted more readily if thrombolytic therapy is administered. Because if you have given the bolus doses of heparin, after that you need to adjust the thrombolytic therapy. Maybe you want to now shift to, after heparin you want to shift to the thrombolytic therapy. So it is more easy to handle this situation. So what are the regime of IV heparin? It's given in the guideline. They give the regime that 80 unit per kg loading dose. After that, you will give the continuous dose 18 unit per kg per hour. This is the dose. And if patient has received thrombolytic therapy, then you will not give the loading dose of heparin, and you just start after thrombolysis, thrombolytic therapy, whatever it is, you will just start directly the infusion 18 unit per kg per hour. Okay, so in this situation, it is mandatory to measure APTT level 4 to 6 hours after the loading dose of heparin. You give the loading dose after 4 to 6 hours, you do coagulation test, and then you can repeat the APT if you have any dose changes, and then you can do daily when in the therapeutic range, you can do daily APTT. So whenever there is a dose changes after 6 hours, you will check the coagulation profile, and then after you give the loading dose, then you have to check for within 4 to 6 hours. Why? Because heparin will disturb APTT, not PT. Because if you remember your physiology, you remember that APTT is representing the intrinsic pathway and the PT is representing the extrinsic pathway. So warfarin will affect more to the PT, the extrinsic pathway, and the this one. the heparin will affect the intrinsic pathway, which is end up in the which is monitored by APTT. So this is long time you have to keep in your mind with warfarin PT extrinsic pathway and with APTT intrinsic pathway and heparin. Okay, so the therapeutic target APTT ratio is usually what you need to do. You have to maintain 1.5 to 2.5. Okay, so definitely every laboratory have their own APTT normalization, and the hematologist advice will be there accordingly. And using this weight adjusted regime, this is because weight adjusted regime is according to the weight 18 unit per kg per hour. The infusion rate should be adjusted according to the APTT. So you can adjust the dose according to APTT. Definitely the hematologist is the one to give you the advice. Okay, so you can see here, this is from the guideline. If they are giving you something, that means they are expecting you also to, even in my exam, they give me this station in the part 3, the bridging prophylaxis. And I didn't know, I first time in my life in that station, I know what is the bridging prophylaxis. So definitely don't think that they will not ask. If they have given in the guideline, definitely they can ask. Okay, so this is the APTT ratio, and the range is 1.5 to 2.5. If it is like that, you don't need to change the dose. You don't need. This is the target APTT. Okay, and the next level you will do daily, 24 hours daily you will do. But if you are changing the doses, you can see you are changing the doses. Then every 6 hours you will do the test APTT. Okay, and then you if the APTT is higher, then you decrease the dose. If APTT is low, then you increase the dose. So this is something you need to do. And if it is more than 3, then you have to stop infusion for 1 hour. So this is what adjustment in the infusion rate of heparin according to APTT. This is the way you do. Okay, so technically, definitely problematic repeating APTT in late pregnancy, because in late pregnancy, what heparin resistance is there, and also why heparin resistance is there, because of normal physiology. At term, there is increased fibrinogen because pregnant women preparing themselves for delivery need more coagulation. So increased fibrinogen and factor 8 is increases at the term. So definitely this increased coagulation factors influence the APTT, and there is a heparin resistance. So you will end up in giving the unnecessary high doses of heparin, definitely with the hemorrhagic problem. So definitely the hematologist will be involved. Also, you can it may be helpful to determine the anti 10A level as a measure of heparin dose. So sometimes they are using this one also. If you are using unfracturated heparin, you need to make anti 10A level at the lower target range. The lower target range is 0.35 to zero point 0.7 unit per ml. Or if patient having life-threatening pulmonary embolism, definitely you have to give more heparin. For that, you can show your target level. You can increase to 0.5 to 1. You can make your target level range. You can compromise on patient, because patient can have bleeding, but right now patient have pulmonary embolism life threatening, so your target level will be show a high 0.5 to 1. Otherwise, normally with heparin, your target level is 0.35 to zero point 0.7. Okay, so life-threatening pulmonary embolism, which patient you give thrombolytic therapy? If patient is hemodynamically unstable, if patient has ischemic complication with extensive iliofemoral vein thrombosis, she has iliofemoral vein also, and also pulmonary embolism, extensive embolism, in this case, you need to thrombolize the clot. So thrombolytic therapy should be considered as anticoagulant therapy alone will not reduce the obstruction in the circulation. So you need to something for lysis. And also, when you give the thrombolytic therapy, you can start the infusion. But in this case, we already discussed, we will not give the bolus dose or loading dose, which will just start with the maintenance dose, 18 unit per kg per hour. Okay. Okay, so what they talk about that thrombolytic agents is more effective than heparin therapy because clot burden will reduce, and also recurrence rate of pulmonary embolism will reduce, because if you will give heparin, it will be, the death will be 19%. So with thrombolysis, the recurrence of pulmonary embolism will be 19% if you will use the heparin alone. But if you will use the thrombolysis, it will be 9%. So there will be the 10% more advantage of using thrombolysis. So current recommendation is you reserve the thrombolysis for severe thromboembolism with hemodynamically compromised patient. Okay, so these are name of the thrombolysis: streptokinase, urokinase, recombinant tissue plasminogen activators. These are the feature, but there is a risk of fetal or maternal bleeding. And if patient is not suitable for thrombolysis, or you need to discuss with cardiothoracic surgeon, urgent thoracotomy. So what are the additional therapies? Catheterization of pulmonary artery so that you can fragment the clot and improve blood flow. This is using the simplest imaging interference equipment, and in ICU this is available. Also, there is a catheter directed thrombolysis because it will you need less thrombolytics, but still data is limited. Okay, so this is the quick confusion that even acute VTE, you will use the graduated elastic stockings or no. So we will use in the effective legs. We will use, and we will mobilize. We'll ask the patient to mobilize, and because pain and swelling will improve, and also the post-thrombotic syndrome will be also it will be prevented. Okay, so they talk about different type of techniques: knee length or with thigh length. They said that the thigh length, if you will use the thigh length, uh, do not offer the better protection against post-thumb than below knee hosiery and are less well tolerated. So you can use below knee hosiery, okay, and because if you will use the thigh length, full length, it will be not well tolerated and patient will be very uncomfortable, and both the thigh length is not more effective in prevention of post-thrombotic syndrome. So better to use below knee hosiery, and it is well tolerated also. Also, the national guidance in the UK, they recommend that the proximal DVT, the proximal, not distal, the proximal DVT, it should be offered below knee compression stocking with an ankle pressure greater than 23 millimeter, and that hosiery does not need to be worn on the unaffected leg. So unaffected leg, no need to wear the stockings. Okay, and also for proximal DVT, you need to should be offered below knee compression stockings with ankle pressure, ankle, because these are the graduated, so pressure will be more at the ankle, then it will come less pressure on the thighs or calf. Yani graduated, the pressure is higher at the ankle, and then when you come above, it will be the less. Okay, accurate fitting and careful instruction is very important so that you will not have it will not prevent the venous return. So it is not like helping, instead of helping, it will cause the ulcers and all those things. So it is very important for fitting. So what is the role of inferior vena cava filters in the management? So these are advanced questions. They told temporary filters can be applied, or if the patient have risk of pulmonary embolism or recurrent pulmonary embolism, and if she's anticoagulation is contraindicated. So in these situations, you can consider a temporary inferior. Long-term safety is uncertain, and there are risks definitely, and these are the risks that these filters can migrate, or they can cause lower limb DVD and caval thrombosis, infection like that. So what is the maintenance treatment? What is the maintenance treatment of DVT or pulmonary embolism? So once the patient have DVT or pulmonary embolism, you started the therapeutic treatment. So what else? You have to finish the 3 months of treatment, whatever it is. So if you give subcutaneous, you will continue with the remainder of the pregnancy for at least 6 weeks postnatally, and until at least 3 months of treatment have been given in total. So total 3 months should be there. Either you complete the 6 weeks postnatally, or you will continue the pregnancy, rest of the pregnancy, and 6 weeks postnatally, and minimum of 3 months. Minimum of 3 months should be completed from the date of this one. And if it is 6 weeks, for example, it is at 38 weeks. From this line, what I understand that if it is a term at the delivery immediately post delivery, you at least total 3 months treatment you have to give total minimum. Okay, if low molecular weight therapy require monitoring, for example, extreme of body weight or renal impairment, then again you have, and I told you before also, when there is extreme of weight or there is renal impairment, then you need monitoring. So what you will do, you have this target level anti-ZA activity, which is zero point 0.5 to 1.2. It is different from that one which where I was talking about unfractionated heparin, and we are talking about the targets which are different, which was zero point 0.5 to zero point 0.7. Or if there is a high risk of massive pulmonary embolism, we are increasing our target to zero point 0.5 to 1 high. But this is different. This is for extreme of body weight or renal impairment. Because of this situation, we need to sometime monitor the peak anti-XA activity 3 hours post injection, which is zero point 0.5 to 1.2. So there are three figures, three types of levels you need to remember. For extreme of age or renal impairment, this is the one. And we talk about unfractionated or life-saving, life-threatening pulmonary embolism, the anti-XA activity, there are different levels. Okay. Okay, the rationale for recommending therapeutic doses rather than reduced prophylactic doses throughout the remainder of the pregnancy is based on the continued risk of recurrence, because risk of recurrence is high because pregnancy related changes in the coagulation system, reduced venous flow velocity, high incidence of isolated iliac vein DVD in pregnancy in at least 50% of patients, um, a thrombophilia will be present. That's why if they will ask you why we need to continue even during the pregnancy, there is thrombosis, why we need to continue at least for 3 months total, because of these factors. Because 50% of the patient, they have thrombophilias, and also they have higher incidence of iliac vein DVT. And because of these things, we need to complete we cannot reduce the prophylactic dose. We need to continue the therapeutic doses. Okay, reducing to intermediate doses may be useful in pregnant women at increased risk of bleeding or osteoporosis. This is according to case to base. Sometimes you want to decrease the dose. Okay. And then you have to see how she will inject, OPD follow-up, clinical assessment, monitoring of blood platelets, and peak anti-ZA activity, 10A activity if appropriate. And then you see patient if have heparin-induced thrombocytopenia or allergy, or you need to discuss with hematologist that there should be alternative anticoagulant like danapride. Okay. And also patient can have with unfractionated patient can have osteoporosis and fractures. And I discussed with you, this is 0.04% with low molecular weight, and with unfractionated it is 2%. So you have to monitor these things. If there is a skin reaction, then you need to change the preparation and less allergic delayed, because always this is the question you can ask, they can ask, what type of allergic reaction will occur with the heparin? It is the allergic delayed type of hypersensitivity reactions, and the medium time of onset is 50 days. The range is 5 to 184 days, but within 50 days of starting the injection, because maybe patient will come to you after 1.5 months, and she said within 2 months, she said in the start there was no reaction. So if you know what is the median time of onset, if you know it can be occur at any time 50 days, or from in the range of 5 to 184 days, it can occur even after repeated injection. The first injection was not allergic, but later on, even within the 184 days, she can have a reaction. So if patient have an intolerance, either you will do alternative low molecular weight heparin, although the cross-reactive reaction is more. So if patient have a reaction with the enoxaparin, then there is a more chance, 33% chance that she will have reaction with the deltaparin or tenzaparin. So better to change the other type. Okay. Where the problem persists, or if the patient with heparin-induced thrombocytopenia, the use of danapride, it is a low molecular weight heparinide, can be considered. It is an effective and safe antithrombotic in pregnancy for women who are intolerant to heparin. So remember the danapride. It is not vitamin K dependent. It is not a new onset. It is not NOx. It is heparinide. It's a low molecular weight heparinide. It can be used an alternative. Okay, so now vitamin K antagonist, which is a warfarin, and it can be used during pregnancy. This is the question, can we use or no? Okay, so because of their adverse effect, vitamin K antagonist is warfarin. It should not be used for antenatal VT treatment. Okay, because they crosses the placenta and they are associated with pregnancy, bad pregnancy outcome like miscarriage, prematurity, low birth weight, neurodevelopmental problem, and bleeding, neonatal and fetal. So also there is some characteristic embryopathy exposure in the first trimester. So what is the role of new anticoagulants? So they said that consideration should be given to the use of new anticoagulant, which is the fondaparinux, argatroban, or R-hydrodin, who are unable to tolerate the heparin, okay, or even heparin or danaparide, and still they need continuing anticoagulants. So what you will do if they cannot tolerate anything? What you will do? You need to give consideration. Although there is a case reports, and they said that these they describe the use these anticoagulants in pregnancy. These are IV, okay, and in fondaparinux, and the mechanism of action is selective factor 10A inhibitor, okay, and the other two, argatroban and R-hydrodin, this is a direct thrombin inhibitor. So you need to know the mechanism of action also. This is a selective 10A inhibitor, and it is a direct thrombin inhibitor they have used in pregnancy. So what they find? They find that these are not licensed for pregnancy. Their safety are reassuring, and the fondaparinux has been recommended by the group of experts. Okay, and but there are no reports on the use of non-vitamin K antagonists, NOACs. Okay, now you need to know these drugs are selective factor 10A inhibitors, this one fondaparinux, and these two drugs, they are direct thrombin inhibitors. So these are different types of drugs. Okay, now we talk about the NOACs, which is called the non-vitamin K antagonist oral anticoagulant. Non-vitamin K antagonist oral anticoagulants. Okay, previously they were called the new or novel oral anticoagulants. Now they have been called non-vitamin K. And these are the rivaroxaban, apixaban, betrixaban, and dabigatran. In my exam, they asked me about the rivaroxaban and the role of rivaroxaban in bridging thromboprophylaxis. So you can well imagine that now these new drugs, they are very useful, especially if there is a renal failure, a renal compromise, and patient is taking these drugs, because these drugs, their effect is long term. So when you plan any patient who is taking these drugs, you need something short acting, because these are long acting, and their effect to remove from the body before surgery is it takes many days. So what will happen? You cannot tell the patient you stop taking these drugs and you come to the hospital for surgery. No, you need something bridging, short acting bridging. So we are using the bridging therapy for heparin, low molecular weight heparin. So these are the things they were talking about, and these drugs can use for renal impairment patients. So okay, we will discuss later on. There is a TOG article on this one also, bridging thrombophylaxis. Okay, so these drugs in pregnancy or the puerperium, and they are likely to cross the placenta, and they have potential direct fetal effects. They should therefore be avoided in the antenatal period. So antenatally you cannot use. Okay, but postnatally, yes, you can use, because now you don't think about the baby. But for antenatally, you will not use these drugs. Okay, these drugs are not licensed for the pregnancy. Okay, so these drugs also you can consider. You can consider if patient is allergic to heparins, you can consider in the pregnancy. But these drugs not for pregnancy, for postnatal only. Okay, so what therapy you will use for labor and delivery? Okay, if patient is taking therapeutic dose, okay, she has thrombosis during the pregnancy, now she come to do for labor, or she have a cesarean section. What is the difference? In prophylactic dose, if the patient is taking prophylactic dose, then you will stop the heparin or low molecular weight you will stop the low molecular weight heparin, before 12 hours for prophylactic dose. But for therapeutic dose, you need more time. So you will stop it before 24 hours. Okay. So this is the difference. Okay, so when VT occur at term, you have to give IV unfractionated heparin because it's more easy to control and manipulate it. If a patient is on maintenance therapy of low molecular weight heparin and she go into established labor, and she should not inject any further heparin if she think that she is going in labor. And if you plan the delivery like induction or elective, then you have to discontinue 24 hours prior to planned delivery. And the spinal should not give, at least they need 24 hours. Last dose should be 24 hours before, otherwise they will not give the spinal anesthesia. Okay. Also, they give the scenario and the strategy that a patient receive. She came in labor. She received her therapeutic dose. So what you will give her? So cesarean section and the GA was the option. So you have to select that one. Okay. So low molecular weight should not be given for 4 hours after the use of spinal anesthesia or after the epidural catheter have been removed. Okay, so definitely when you give the spinal anesthesia, you immediately remove the needle. So when you remove the needle, at least for this needle, at least 4 hours, you should not give heparin because the needle side can bleed for 4 hours. You should not give heparin. Either you remove the epidural catheter. After removal, 4 hours, you have to wait because the puncture site can bleed within 4 hours. This is very simple. So when to remove, because sometimes epidural catheter you are not removing immediately after delivery, maybe after 6 hours you are keeping the catheter, maybe sometime more. So when you remove the epidural catheter, after that 4 hours you have to wait. If spinal, definitely after 4 hours you have to wait. So the epidural catheter should not be removed within 12 hours of the most recent injection, and also you will not remove the catheter unless the last dose will be uh, within 12 hours, at least for 12 hours, because if you will remove the epidural catheter and the last dose was less than 12 hours, then again the removal site will bleed. Okay, so you need to understand this thing. For therapeutic dose, 24 hours before any anesthesia, you have to wait 24 hours. Okay, and just one minute. Okay, so 24 hours you understand, and then for spinal, at least wait for 4 hours when you remove the spinal needle, and the epidural catheter wait for 4 hours, and you should not insert it epidural catheter within 12 hours of the most recent injection. So you should not be removed. That's why spinal epidural little bit different, because sometimes epidural you keep with the patient post operatively also. Okay. Okay, so subcutaneous unfractionated heparin should be discontinued 12 hours before. So for heparin, different. For low molecular weight heparin, it is 24 hours. For heparin, subcutaneous heparin, there is a subcutaneous form also. It should be discontinued 12 hours before, and IV should stop 6 hours before induction of labor or regional anesthesia. So for heparin, the time is little bit less because it's short acting. So that's why we are using this one. So for IV, you can stop 6 hours before, and for subcutical, you can stop 12 hours before. Okay. And if patient is go in spontaneous labor, she was receiving the therapeutic dose of subcutaneous fractionated, you need to monitor APTT. And if it is very prolonged near delivery, you need to give the antidote protamine sulfate. Okay, so women who present in labor shortly after injecting low molecular weight heparin can be reassured that bleeding complications are very uncommon with low molecular weight heparin. Okay, so if VT occur at term, recurrence rate may be increased uh, because if you will stop the anticoagulation, allow the delivery and cesarean section, so the recurrence VT is higher within 2 weeks of the initial thrombosis. So the 2 weeks, at least 2 weeks, you should be very vigilant. Okay, so what you need to do, you can use the IV heparin because you can manipulate, it has short half-life, and you can minimize the duration without anticoagulation therapy. And there are issues in monitoring unfractionated pregnancy using the APTT. This is a problem with this one, because APTT monitoring is important with this one. But definitely during the pregnancy, as we discussed, that after thrombosis, the coagulation factor decreases, heparin resistance increases. That's why APTT monitoring is difficult. Okay, they talk about spinal hematoma incidence after regional anesthesia. It is unknown, and but anyhow, it is lower incidence of spinal hematoma in obstetric patient than elderly patient. And epidural anesthesia can be given without undergoing treatment for VTE, only after discussion with senior anesthetist, and you have to discuss with the local anesthetic protocol. Okay, so we already discussed for elective cesarean 24 hours before low molecular weight heparin should be stopped. And now what is post-operative? Thromboprophylaxis dose of low molecular weight heparin, like because you are giving prophylactic dose, it is 40 or maybe deltaparin 5000 or tenzaparin 75 unit. You can give 4 hours post-operatively. Okay, so after 4 hours, usually what we are writing in our protocol of cesarean section, we are giving after 6 hours in our, this is our hospital protocol. But ideally you can give after 4 hours of any surgery, you can give 4 hours. So 4 hours is safe period. Okay, you can give 4 hours. So what you will do for thromboprophylaxis, you will give low molecular weight heparin 4 hours. Okay, or if epidural catheter have been removed, after removal 4 hours. And then you can start treatment dose 8 to 12 hours later on. So they talk about prophylactic dose here, because you stop the therapeutic dose 24 hours before. Now you don't want, because risk of thrombosis, because already 24 hours last dose was there, then you do cesarean, or maybe you do induction of labor, and then patient go in labor and deliver, so maybe more time lapse in between. Now you want to start, if patient have vaginal delivery, immediately you can start. But if the patient have surgery, at least you need to wait 4 hours. After 4 hours you can give prophylactic dose, and after prophylactic dose 8 to 12 hours you can give the therapeutic dose. So there is some safe period. Okay, for surgery you need to, you have to be more careful. After prophylactic, then you can start the therapeutic dose. Okay, so what are the surgical measures required for anticoagulated patient undergoing delivery by cesarean section? So during surgery, what you will do, during surgery, what you will do, you can put the drains. If the patient is receiving therapeutic doses, one drain is abdominal drain, and then rectus sheath drain, 2 drains. And then you can consider interrupted sutures, so that there will be no hematoma. Also, okay, you already put the drains. Okay, so definitely you need to tell the patient that risk of wound hematoma will be 9% if the patient have receiving anticoagulation, and this we need to tell during counseling, because this patient 9% is too much. Okay, so anticoagulant therapy should be employed in women at high risk of hemorrhage. What to do if the patient have high risk of hemorrhage? What to do? Okay, if the patient have high risk of hemorrhage, and you need to think that heparin therapy is need to be given. So in these cases you need to give IV unfractionated heparin. Okay, so because it has shorter lifetime and it can be reversed, so same point. Okay, so what are those situations in which anticoagulation is required, but there is a concern with the bleeding? These situations are APH, because placenta previa, if prolonged admission during the hospital you want to give, but you are afraid of bleeding also. And coagulopathy, progressive wound hematomas, if the patient have hematoma postpartum, but you want, because she's admitted for purpurium, then what to do? Okay, and then suspected interrupt abdominal bleeding and postpartum hemorrhage. So these are the situation in which you want to give anticoagulation, or you want to you have risk of bleeding also. Okay, if patient have hemorrhagic problem, if she's receiving low molecular heparin, you need to stop the treatment. You have to call the hematologist. Protamine sulfate reverses the anti 2A fraction of low molecular weight heparin. So if low molecular weight heparin, this portion will be reversed, but anti-10A effect will not be reversed. So this is important, that this one partially reverse the effect of low molecular weight heparin. So sometime even if you have no other choice, still you can give protamine sulfate, because sometimes it is useful, but not all patients. So antenatal anticoagulation, how should anticoagulation be managed postnatally? Now we come to postnatally. So okay, so anticoagulation therapy you need to for the duration of the pregnancy and for at least 6 weeks postnatally, at least 3 months of treatment has been given in total. So total 3 months, because maybe if the patient have for example, if the patient have clot formation in the first trimester, then at least during the pregnancy 3 months you have to complete. Okay, and then after postnatally you will give 6 weeks postnatally when she will deliver, then you will give. And during the pregnancy, rest of the pregnancy, maybe you want to give prophylactic dose accordingly. Okay, but at least therapeutic dose is 3 months. And if patient have at the end of the pregnancy, then at least 6 weeks postnatally you have to give. Before discontinuing treatment, the continuing risk of thrombosis should be assessed. You have to assess the continuing risk of thrombosis. Women should be offered a choice of mm, low molecular weight heparin oral anticoagulant. Now we have more options. We can give warfarin also postnatally, but we have to tell that for this one we need to monitor the regular blood testing, especially during the first 10 days of treatment. So this we need to tell the patient if she don't want IV, if she don't want subcutical this heparin. Okay, at least for 5 days postnatally you should not give warfarin. Okay, because within 5 days patient will have increased risk of PPH. So there is one regime, there is a table, I will show you how they convert this one. And both warfarin and unfractionated heparin, mm, they they are not contraindicated. You can a patient can have breastfeeding, and since neither type of heparin is orally active, so there will be no clinical effect on the baby. Okay, also warfarin does not pass into the breast milk, so it is 99% bound to the serum proteins. That's why it will not transfer to the breast milk. So this is important. This question can come in the exam, because breastfeeding and warfarin and patient worry. Okay, so if patient is not breastfeeding, because NOx, they say that if the patient is not breastfeeding, you can consider. And before discontinuing treatment, the continuing risk of thrombosis should be assessed. Okay, so low molecular weight initially, then you have to convert to the warfarin, but warfarin should be at least 5 days you have to wait, because when you are switching to warfarin, you can have secondary PPH, and you will stop low molecular weight therapeutic molecular weight only when you want to convert to the warfarin, only when the INR is greater than 2. Okay, because you want to keep the INR 2 to 3. This is the target. You need to keep the INR 2 to 3. Okay, and warfarin, when you are switching from low molecular weight heparin to warfarin, at least you have to wait 5 days postnatally, and you will stop low molecular weight heparin, because warfarin will take more time to start its action. Okay, so at least INR is greater than 2. Okay, so when during the transfer from low molecular weight heparin to warfarin, you need to avoid over anticoagulation. So daily INR is important. And if patient at a risk of hemorrhage PPH, maybe you want to wait more than 5 days. Maybe you want to wait 1 week if patient have high risk of PPH. Okay. Sometime they said you need more high doses of warfarin, because therapeutic INR, it takes more time because of coagulation changes of pregnancy, and it persists in the puparium also, and they also antagonize, like in the pregnancy heparin, they antagonize warfarin also. So sometimes you need more loading dose. Okay, so you need to discuss with the hematologist, and INR daily. and then on day 2 of warfarin, and then subsequent. Basically, what you need to remember, the INR should be maintained between 2 to 3, and heparin treatment should be continued until the INR is greater than 2 for at least 24 hours. So you will not stop low molecular weight heparin or heparin until INR is greater than 2 for last 24 hours. This is the target, okay? Or okay, we already discussed this thing. This one I already told you. So what is the prevention of post-thrombotic syndrome? What measures you can do? They said that if you will use low molecular weight heparin more than 12 weeks, you can reduce the chance of post-thrombotic syndrome. And also, they said that after DVT, the patient should have graduated elastic compression stocking on the affected legs, not on the both legs, on the affected legs. So, but the prevention of post-thrombotic syndrome after wearing the compression stockings is unclear. They have many studies in the guideline. They discuss about many studies, but they don't. This is very unclear because some of the studies shows that there was benefits after compression stockings, and some of the studies shows there is no benefit. So you have to counsel the patient accordingly. But it's better if the patient take 12 weeks low molecular weight heparin. And this they say that this syndrome is characterized by like swelling, pain, and heaviness, cyanosis. These are the symptoms you can see here. Okay, the prevalence is 42%, and there is proximal postnatal thrombosis, smoking. These are the risk factors. Okay, so if the patient have proximal thrombosis, if the patient is smoker, if the patient is more than 33 years, if the patient have recurrent ipsilateral DVD, if the patient was obese, these are the risk factor for post-thrombotic syndrome. So you have to remember these risk factors, because if any scenario in which they will give patient is 34 years with BMI of 34 and she has DVD or like this, now she came to you with these symptoms, you think about this post-thrombotic syndrome. Also, what you will do postnatal clinical review, what we need to do, we need obstetric medical clinic or joint obstetric hematological clinic. And then you will do thrombophilia testing only when the anticoagulation therapy has been discontinued, because definitely the result will influence. Okay. And definitely acute treatment, you will give the patient therapeutic treatment. So whether you do treatment test or no, it will not affect the treatment. But definitely you need thrombophilia testing postnatally after finishing the purpurium. Why? Because next time the prophylaxis, you need to give patient high dose prophylaxis from the start of the pregnancy or from 28 weeks of pregnancy, the prophylaxis will affect. So definitely thrombophilia screening will help in the future pregnancy. But right now in the acute DVD, acute pulmonary embolism, thrombophilia testing will not help. So even in the postnatal, you will not offer. Okay, so what you will do in the postnatal, you will say post-thrombotic venous damage, you will see, you will give the advice accordingly, future pregnancy advice. Hormonal contraception, I will show you the chart, hormonal contraception, uh, wait. This is another topic and I am very tired now, 2 hours. I think you all are full now. Okay, so this is UK medical eligibility criteria for contraception use. Okay. So if the patient has history of venous thromboembolism, the OCPs are 4 category. And if she's current VTE on anticoagulation, still it is 4. Okay. So, but the POP and the implant, this depot, marina, and copper IUD, you can see 1, even 2 to 2. So if the patient have postpartum 6 weeks, so she's not breastfeeding and she want you to, okay, I have DVD, now I'm taking this medication or whatever she's taking, anticoagulation she's taking, and she has DVD, and after, if she's not breastfeeding or breastfeeding accordingly, you can start for her progesterone, you can start for her. So it's very clear here. This UK, and I took from strategy, and this is very clear there, UK MAC criteria. So don't hesitate to start the implants or depot or for these patients. Okay. For emergency contraception, this copper IUD, ulipristal acetate, and levonorgestrel, it is UK MEC2 with a history of DVD, even current VTE, you can give safely. So this one was the first day of treatment, warfarin. You give the dose of warfarin, maybe day 5 of postpartum. You give the patient, for example, 7 milligram of tablet warfarin. Okay. Then second day you give 777, and for third day you start to monitor INR. You can see here you start monitoring INR, 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 like that you are monitoring. So if INR is 2, you keep the dose same, but if INR is becoming more, you are decreasing the dose. You can see here you are decreasing the dose of warfarin. If INR become more than 4, you stop the warfarin. So this is the guideline that you have to keep the INR between 2 to 3. I think that was the target now. Yeah, something where 2 or 2 to 2 to 2.5, something here. You want to keep your INR here. So if INR is more, then you have to decrease the warfarin dose. This is general concept you need to understand. You have to maintain the INR and 2 to 2.5. And then if INR is more, then you have to decrease the dose. And if more than 4, you have to stop the warfarin. This is from Green Top guideline. Okay. So what you will do if the patient has suspected pulmonary embolism, clinical assessment, then perform X-ray and ECG and do blood test, and then start the low molecular weight, this one, unless treatment is contraindicated. If patient with suspected pulmonary embolism, if patient have sign and symptom of DVD, if she has, then what you will do, just do ultrasound or legs, and if compression ultrasound confirm DVD, yes, you start therapeutic dose. If there is suspected pulmonary embolism but no sign and symptoms of DVD, okay, or even if compression ultrasound is negative, what you will do, you do chest, you already do chest X-ray immediately. You see chest X-ray normal, yes. Abnormal, not abnormal, chest X-ray is abnormal, then definitely abnormal chest X-ray, you do CTPA. If chest X-ray is normal, but you suspect pulmonary embolism, what you will do, you perform ventilation perfusion scan, confirm pulmonary embolism, no, okay. If clinical suspicion is low, discontinue and alternative diagnosis consider. And if clinical suspicion is high, then you do alternative repeat testing and you will continue the low molecular weight heparin, okay. If confirmed, you will continue the therapeutic dose of heparin. So this is the summary, okay. This one, okay, this one, low molecular weight heparin and warfarin, there is a comparison table. So comparison table, you can see here for low molecular weight heparin, what you will do, the assay, you will anti-10A assay. You will monitor this drug with the anti-10A assay, okay. You will adjust the dose according to the BMI. With extreme of age, you will adjust the doses. It is not crossing the placenta, it is not teratogenic, and osteoporosis risk is 0.04%, okay. Unfractionated heparin, you will monitor this one with APTT. You will keep the APTT 1.5 to 2 of the normal. It is not crossing the placenta, it's not teratogenic, and osteoporosis risk is 2%. And the last is warfarin. Warfarin is monitoring by INR. You keep the INR between 2 to 3. Crosses the placenta, warfarin, yes, that's why you are not giving antenatally. And teratogenic, yes, and osteoporosis risk is no. Okay, so I skip the thrombophilic part, I skip the mechanical heart, I skip because I think 2 hours and enough for you also. Any questions? Too much knowledge is right. Too much knowledge. Any questions?
Yes, ma'am.
Are you alive all? Or I cannot hear anybody of you. Anyone?
Yes, ma'am. Yes, ma'am.
Okay. Any
Yes.
questions?
We will read and we will try to understand more.
Yes, actually, I gave you topic yesterday. You have to read. You have to read both guidelines. So
Yes,
you are
yes, yes,
supposed to come prepared. Like I am reading since
yes.
this guideline yesterday, so I
Yeah,
can
yeah,
be able to tell you. If you are not coming prepared, it will be difficult for you,
yeah.
definitely.
Yes,
So
yes,
go today,
definitely.
and maybe tomorrow I will be, because for tomorrow, day after tomorrow, tomorrow will be my after vacation first day of my duty, and hmm, wait.